Hello, my name is Francisco Ponce. I am going to be presenting on a patient case of my patient May Jeffries today. The patient is a 52-year-old female who was admitted on May 4th, 2016 with a chief complaint of shortness of breath. Some history on her present illness. The patient presented to the emergency department after referral from our primary care provider. She had been experiencing shortness of breath the prior 2 weeks, and so she went to an urgent care for treatment where they gave her prednisone 50 milligrams daily for 5 days. She finished the course, and it helped her out while she was taking the medication. The pain and shortness of breath was gone, but as soon as this course of corticosteroids was finished, the shortness of breath returned. So she went to her primary care provider, where he sent her in to do a CT scan to see if she had a pulmonary embolism, which they found she did. So she was then referred to the emergency department, and then she was admitted. So some past medical history of her is she has asthma, hypertension, hyperlipidemia, type 2 diabetes, depression, hypothyroidism, fibromyalgia, urinary incontinence, chronic headaches, GERD, eczema, and lower back and right ankle pain. Past medical history of 2 foot surgeries, total abdominal hysterectomy, right knee surgery, breast reduction, and tonsillectomy and adenoectomy. Family history is mother deceased and is had a history of temporal arthritis. Father he has ESRD, a pacemaker, CAD, DM, and hypertension. She lives alone on disability, denies tobacco, alcohol, or illicit drug use, and she has an allergies to cephalosporins, COX-2 inhibitors, and Darvocet. Home medications. She was on Benazepril 10 milligrams daily, Synthroid 75 micrograms daily, Glipizide XL 10 milligrams daily, Atorvastatin 20 milligrams daily, and Oxybutynin 5 milligrams daily. And those are the ones that were continued inpatient. No, we had no records of her immunizations. Total body weight, she weighs 122 kilograms, ideal body weight being 59.3 kilograms, and her adjusted body weight being 84.4 kilograms. Her vitals were all within normal range. The only one that is still within normal, but it was on the lower end, was her blood pressure. It was 108 over 75. Um, and then for her labs, they were all as well within normal range, with the only two being out of normal range, being chloride, which was elevated by 1 point. So I don't find that very significant. And then potassium, which was at 2.9, which it is more severely lowered. Radiology, like I stated earlier, found a mass consistent with a saddle pulmonary embolism on the left proximal pulmonary artery. For inpatient, you can refer to her chart. But she just continued a lot of the same medication she was on. We added enoxaparin and rivaroxaban, and the lisinopril dose was increased to 40 milligrams, and her atorvastatin dose was increased to 20 milligrams as well. List of her problems in order of importance. Her chief complaint I put as number one, so shortness of breath, then pulmonary embolism, hypertension, hyperlipidemia, and then diabetes. So for shortness of breath, the patient seems to have been experiencing shortness of breath and coughing due to her pulmonary embolism. The patient also has a past medical history of asthma with no rescue inhaler on her medical profile. So my recommendation is the addition of an emergency inhaler to the patient's therapy, specifically albuterol, 2 puffs by mouth every 6 hours as needed for cough. Shortness of breath or wheezing. This would serve as the patient as a rescue inhaler if she would need it. The patient should be monitored for how often the rescue inhaler is having to be used, blood pressure, heart rate, and CMP. Specifically, glucose, potassium, creatinine should be monitored for the albuterol. A follow-up appointment can be made in 4 weeks after this. For pulmonary embolism, the patient is currently receiving enoxaparin to treat her pulmonary embolism, but according to the ISTH guidelines, use of rivaroxaban is not recommended for obese patients or those weighing greater than 120 kilograms, which the patient falls into both of those categories. This is due to an uncertainty with the pharmacokinetic and pharmacodynamic parameters as well as efficacy. DOAC should be received as a second-line therapy in patients who can't take vitamin K antagonist. So my recommendation for this is that we start the patient on warfarin 5 milligrams by mouth daily and use enoxaparin 120 milligrams subcutaneously every 12 hours to bridge therapy until the patient's INR is between the goal range of 2 to 3. which usually takes about 4 to 5 days. The patient's INR should be monitored every 3 days during the first week of therapy to determine if the INR is within goal range and if we can discontinue the enoxaparin. INR should then be monitored every 2 weeks and then monthly thereafter when INR is stable. Additionally, patients should receive routine monitoring of CBC and CMP at 4 weeks when the patient has follow-up appointments. Third problem is hypertension, where the patient presented to the emergency department with a blood pressure of 108/75 and was told to discontinue her hydrochlorothiazide due to hypotension. I was later found out that she also was hypokalemic. Prior to admission, the patient was on benazepril 10 milligrams, but once admitted, the dose was raised to 40 milligrams. During hospitalization, the patient received an additional medication for her blood pressure, amlodipine 5 milligrams daily, and was told to continue this after discharge. The increase from 10 milligrams to 40 milligrams of her ACE inhibitor could cause hypotension, since the patient was hypotensive with the 10 milligram regimen. Our recommendation is to reduce the patient's benazepril dose back to 10 milligrams to avoid hypotensive episode and continue amlodipine 5 milligrams daily. Since the amlodipine is a new agent, the patient should begin self-testing her blood pressure and heart rate at home daily to titrate doses needed and watch out for side effects with amlodipine, including constipation and peripheral edema. Readings from the patient's dog can be assessed at the 4-week follow-up and appointments. For her hyperlipidemia, the cholesterol labs are pending, so we currently didn't know what the patient's being adherent to her medications or if it's being effective. The patient's comorbidity of diabetes and age greater than 40 puts her in a category where a high intensity statin is recommended. So my recommendation is to increase the dose of her atorvastatin from 20 milligrams to 40 milligrams. Once a day if the patient can tolerate it. To monitor therapy, patients should make an appointment with her PCP 4 weeks after discharge to get a complete lipid panel performed, our CMP to assess renal function, LFTs, and CPK if the patient has muscle pains that could indicate rhabdomyolysis. Diabetes, the patient was started on metformin while hospitalized, and this agent should be continued after discharge. The patient wasn't initially on metformin, but with metformin being the first-line agent for diabetes, we could add it to her profile. Metformin SR, 500 milligrams by mouth daily, and glyphosate XL, 10 milligrams, 2 tablets daily should be continued for the patient. The patient has received a prescription for a blood glucose monitor and should begin testing her fasting preprandial and blood glucose every day. Additionally, the patient should get her A1C tested at least twice a year, and her renal function should be assessed annually while on metformin. Thank you.